Thanks very much, and thanks for the organisers for inviting me here today. So I find this is a really interesting topic, and I've been asked to talk about standardized management protocols and neurocritical care, and really talk about the two elements, the progress we've made and as well the pitfalls. And this is really relevant because we are caring for critically ill patients who it really remains challenging because our time is divided up by other seriously critically ill patients, in addition to the increasingly large amounts of clinical data, laboratory data, and imaging data. And when we look at maybe other general critical care populations like ARDS and sepsis, when we look at them, whether they get an appropriate evidence-based medicine, we find that a lot of the times we're a little lacking. And it's been hypothesized by using protocols, we may be able to deliver more standardized best practice care. And so I think it's very relevant to discuss it in neurocritical care. So I'm going to move on and just say I have no disclosures for this talk. But to talk about this, we really need to think about neurocritical care and how it's delivered, because it's somewhat of a black box. And there's many different ways that we can deliver neurocritical care. And even within Toronto, where I work, there's many different ways. And that may, as a way of delivering it, it may be as an ICU structure, so a dedicated neurocritical care unit. It may also be a staffing thing, so you may actually have neurointensivists who join the critical care team. But another way of delivering neurocritical care in general ICUs has been the approach to think about the processes of care and think about standardized management protocols. And this is important because when we look at systematic reviews of how neurocritical care has been improving outcomes, and Professor Menon was talking in his talk that over the past couple of decades we've seen improvements for acutely brain injured patients. There was 2 systematic reviews, most recently by my Canadian colleagues, Andreas Kramer and David Egan, last updated in 2014, where they were looking at whether there's this large signal for improved outcomes in neurocritical care, and why does it make a difference? And I've just made this table to highlight that it was a very heterogeneous intervention. And so while we think about neurocritical care, we think about dedicated units, but actually grouped together, there was a number of different ways, like we talked about, that conceptual model. And actually so there was intensive care, it was delivered by neurointensivists, but actually standardized management protocols were up to about 40% of the way that we are delivering our neurocritical care. When we look at the results here, we can see that the red bar here is below that favors neurocritical care, and I think I've just highlighted here to show that when they grouped all this together in a meta-analysis, they find that consistent trend for an improvement in mortality and an actually increase in favorable outcomes when you care for patients in a neurocritical care environment. And so the possible mechanisms of why this may work is being hypothesized to think about maybe higher patient volumes that's giving us greater clinician experience, and through that we may have a more conservative approach to neuroprognostication and utilizing more neurophysiological monitoring to allow tailored approach. But my graphics are a bit off there. But the other thought is adherence to standardized management protocols, and that's really what I want to delve into. And this is a great paper by Chang and colleagues in critical care where they were really trying to explain how we think that protocols improve care. And people talk about it being an educational bundle. I actually don't think it's an educational bundle per se. You can't educate someone in a tick box, but I think it really helps as a cognitive aid and as a communication aid to try and bring up that the baseline to provide a standardization of care. And in that no way means that you can't individualize on top of that. I know we get a bit stuck on protocols and we have to do it to the T, but I really believe in giving a good standard baseline of care, and I think protocols allow that, and then still allowing to tailor your approach on top. But I think some of the great things through protocols seem to come through the facilitation of communication, especially with the interprofessional team, where through the protocol we may create standard terminology, so we're all talking about the same thing. I can't tell you the number of times that from sub-Iraq patients that we're all talking about, radiographic clinical spasm, delayed cerebral ischemia. We're using so many different terminologies. It may also help us to reduce our cognitive load, so we just need to make sure we're doing the basics right. And so while we're dealing with that other septic patient and the ARDS patient, our neuro patient's getting the best care. And then help us to at least adopt, maybe not evidence-based, but best practice, because neurocritical care, the evidence base isn't as good as maybe general critical care. So at the bedside, I would say that how does it help? So we try to detect secondary insults with much more of a neurophysiological monitoring approach. And I feel that from a protocol perspective, the standardized management helps us to translate this at the bedside. And a really great example of this is the Boost 3 study from Laurie Souter and colleagues who are about to look at brain tissue oxygenation plus ICP monitoring versus ICP alone. And the way that they've done that is pretty novel, and they're using a bedside monitor that includes the protocol in it. So it helps to actually at the bedside remind you to achieve those targets within that trial. And that result will hopefully be out in the next couple of years, but they're just starting to get up and running with that. If we look at a more syndromic approach to standardized care, this is a systematic review by, again, my Canadian colleagues, Shane English and colleagues, looking at using brain trauma foundation guidelines as a way to standardize the care for severe traumatic brain injury. And they find about 13 observational studies that they found overall there was an improvement at 6 months for an improved favorable outcome when a center used a standardized approach, adhering to most of the recommendations in the Brain Trauma Foundation. But there are some limitations to this literature, and I just want to highlight a few of them. And through that systematic reviews, both from Andreas Kramer and as well as Shane English, we saw that a lot of these are single centers. We're really comparing historically to older open general critical care units compared to more modern closed units. And there may be a publication bias. You're probably not going to get your neurocritical care study that shows great improvements if you actually didn't show any improvement, whereas you're much more likely to be published if you've shown an improvement in your intervention. So knowing this, we actually looked at 134 centers within North America, and we were looking at severe traumatic brain injury and looking at the different structures and processes of care of how we might help to improve outcome. And so we looked at 2 domains. One was the ICU structure that we talked a little bit about dedicated neurocritical care, but we also looked at standardized management protocols, and they really incorporated looking at intracranial pressure parameters and brain tissue oxygenation. And they found, what we found overall was that dedicated neurocritical care units compared to general ICU wasn't associated with a lower risk adjusted mortality. But when a center had a standardized management protocol for dealing with intracranial hypertension after severe traumatic brain injury, that was associated with improved in-hospital mortality. I have to stress that every center, though, used their own protocol. It wasn't as if we sent out one standardized protocol to all these centers. It was just merely the presence of a protocol in their unit. And we did a number of sensitivity analysis to see if whether excluding units that were open, looking at junior training facilities, looking at academic, and throughout this our results were robust to show that standardized management protocols were associated with improved outcome. So let's talk about some of the pitfalls or the concerns with using standardized management protocols. And we're just going to jump over to the general critical care literature here. And this is a paper by Dr. Seberansky and the Critical Care Injury Trials Group in the US, on where they were looking at a dose-response relationship. Because if we think a standardized management protocol helps improve outcomes, we would hope to see that the more protocols were used in a dose-response way, we might see better outcomes. And so they actually split the median number of protocols within their centers, which was, I think, over 100. They find that the median number of protocols was 19. And so here you can look at over the number of protocols increasing, that there was no improvements in overall mortality. And they actually find that centers that had a very high number of protocols versus centers that had a low number of protocols, that there was no difference in ICU mortality, length of stay, mechanical ventilation. So there doesn't seem to be this dose-response relationship that we're looking for. They actually went on to say, well, maybe it's just the protocol adherence, because so far we've been talking about protocol presence. And so they looked at protocol adherence for lung protective ventilation and as well as spontaneous breathing trials. And they found that actually both were only about 50% in their adherence to the protocols. But I think that's an issue with the literature, that we've looked at presence, but we don't always look at adherence. And so when we look at this study by Severansky to say that overall there was no improvement with the more number of protocols we have in a unit, we can say that we're hopefully bringing up the baseline, we're standardizing care, and so we're probably bringing up, hopefully, the standard of care for a number of patients, but I think our concern or the pitfall that we all get worried about is that there may be a number of patients where we're actually potentially bringing down that care by standardizing and not allowing ourselves to tailor or individualize, kind of losing the art of medicine. And I think that's one of the big concerns that people talk about in the literature about standardized management protocols. How about just doing things, simple things right? This was actually using the same data from the Severansky study and just looking at neuro patients here. And they wanted to see whether ICU protocols, all the good things like lung protective ventilation, VAP prophylaxis, whether we didn't adhere to it so much in neuro, because we've really been emphasizing that a lot of the big studies in general critical care actually excluded brain injured patients. And that's probably reflected by we're not quite sure, just like Dr. Singh was talking about PEEP and lung protective ventilation and brain injury in the session before me, in the talk before me, is that we probably aren't so sure whether we should be applying that same data. And when they looked at the utilization between neuro patients versus non-neuro, they could actually see that for the majority of them, for lung protective ventilation, VAP prophylaxis, and early mobility, we really weren't in the neuro group adhering to any of these standardized protocols. There was a significant difference. What I find interesting, though, is there were actually a higher adherence to ventilation weaning protocols in neuro. And that's probably because our brain injured patients have primary brain failure as opposed to lung failure. They don't really need a mechanical ventilator. They have airway failure because of their brain failure, and they need a conduit for their airway. But they can usually be weaned from their pressure support unless they get that brain crosstalk and they get a lung injury. They can usually be weaned much quicker than our general patients. So moving forward, looking through where the progress and where we're at with the literature, and then really talking about some of the concerns and the pitfalls, looking for the way forward. This was actually a nice idea from some slides. Professor Kavanagh gave a talk a couple of years ago, and it's come also from a Blue Journal paper in 2012 about when you might think about using a protocol and why not. And really a good idea, I think, would be something that's inherently simple, that you're trying to minimize the variability and there's explicit knowledge about. So say a potassium replacing regime, while as potentially caution trying to create a standardized management protocol for something that's just too complex and involves judgment and tacit knowledge. So the heuristics of why you do something is kind of hard to put down on paper. I think we have to be very cautious about over-protocolizing those very complex elements of neurocritical care. So in conclusion, we've seen that overall neurocritical care, the field is evolving vastly and that outcomes are improving over the past couple of decades. And as we're looking to go back to our units and think how we can invest and try and improve outcomes for our patients, it may be that using standardized management protocols may be more practical targets and a low-cost intervention than trying to create a whole new physical neuro-ICU. And trying to understand, though, some of these elements of the management protocols that seem to be improving outcomes or associated with improved outcomes, and trying to actually capture adherence to your protocol and your unit really warrants further study. So I'm going to thank you all for staying and listening. And just my last talk, I'm going to put a plug in for our critical care fellowship program. Thank you very much.